Oh, okay. Here we go. Okay. Now can you see it?
Yes, we can. And if you hit
Okay.
the slideshow view, yep, that looks
Okay.
perfect.
All right. Well, today what I'm going to be talking about is providing an overview of the work that I've been doing, and in particular, uh, the work that I've been doing tracking COVID trends among the Latino population. Um, I'll mention an article that a colleague and I did on the Latino paradox and the COVID-19 era, and then an analysis that I did for the Dallas Morning News on person years lost to COVID-19 in Texas. So I'll talk about the ongoing. So I started the work back in late March or early April, where it was very obvious that people of color were being disproportionately hit by COVID. And there was information that was coming out with respect to African Americans, particularly looking at how they were much more likely to be contracting the virus and dying from it compared to the white population and so forth. And then, so I started putting together data for the Latino population, and I started by visiting the state portals and pulling out information. And early on, in April 6th to the 9th, there were only 6 states and DC that were providing information on Latino cases or Latino deaths. And there were also 3 cities: Milwaukee, New York City, and San Francisco. And from there, fortunately, in about several weeks or so, there were uh, some like the CDC, as well as the race tracker uh, was compiling that information. And I put together blogs for the Latino decisions. And I had a blog in May, June, July, and August that was keeping track of what was going on. And these are the data that I was using, one from the COVID tracking project, and in particular the COVID racial data tracker, and then the CDC health disparities, race and Hispanic origin provisional death counts. Quite a bit of methodological issues with the data. Of course, the big one is that the data are provisional, so the portrait is always changing. And then with Latinos not being a race, that also presents some issues in terms of comparing to the white population in particular states and so forth. And for these data for the Latino population, the data aren't broken down by gender either. And this is the kinds of trends early on from May through September, and then what we see in February 2021. And then at the top there, you have states where Latinos are overrepresented among COVID-19 cases. And then at the bottom is with respect to COVID-19 deaths. And very early on, it seemed like Latinos were disproportionately being hit by the virus, but they were less likely to be dying from it. For example, in May, there was 1 out of 29 states, only New York, the state of New York, minus New York City, where Latinos were overrepresented among the dead. And of course, what that had to do was the age structure of the Latino population. So here you can see the median age of Latinos, 29.5 versus whites at 43.6, 7% of Latinos 65 and older compared to whites at 20%. And you can see on the right-hand side, the age-adjusted death rates, you can see much higher for Blacks and Latinos and American Indians. Back in September, Latinos were dying at 3.1 times higher than whites, and 2.4 with the latest data. And we also find that among the 48 states, including DC, that have data for mortality of Latinos COVID, with the age-adjusted death rates, Latinos have higher age-adjusted death rates than whites in 39 of the states. One of the things that is very obvious that stands out is the demography of differences between the COVID fatalities among Latinos and whites. And I have here US, Texas, and California, and it's pretty consistent. But in the US, for example, we see that close to 90%, 89.4% of whites who have died from COVID are 65 and older, compared to 63% for the Latino population. And 50 to 64, you can see that a little more than 1 in 4 Latinos have died that were in that age group, compared to 1 of 11 in the white population. And then in the under 50, 11% of Latinos have been under 50, compared to less than 2% for the white population. And this has to do with I think with the Latinos being more likely to be in the front lines as essential workers and so forth. And then one of the things I was also very interested in, what was going to happen with the Latino paradox. Latinos have been dying at rates in the last 2 decades or so, about 20% lower than the white population. And then just thinking what's going to happen with the paradox, and we find that the paradox holds when it comes to non-COVID deaths, but in the COVID era, you have much higher death rates among Latinos and whites. And overall, when you look at the total deaths, we see that there are particular age categories where the paradox has given way. This is a article that we had in Journal of Gerontology, Series B. And at that point in time, it showed, for example, that at the 65 to 74 age category, Latinos already had higher death rates than whites for the total deaths. And we're very close also at the 55 to 64, 75 and 84, and a little bit more distance in the 85 and older category. And then the piece that I did for the Dallas Morning News, this was part of an article that one of the science writers did. And she asked me to do some calculations with the years lost to COVID-19 in Texas. So I put together some analysis with life tables for the US and then adjusted for Texas. And then what I was estimating is that from February 1st to December 5th, about 18 was the average age person years lost in Texas, but much higher for Latinos, 20 versus 14.5 for whites. And overall, during that period, the person years lost in Texas was a bit more than 405,000. And of that, about 60% of that was due to the Latino population. And we continue to see Latinos, about 50% right now of people who have died in Texas from COVID have been Latinos. And I think that should be the 9 minutes or pretty close.
Thank you very much, Rogelio. You came in a little under 9 minutes, actually. So congratulations.
Okay, I was talking pretty fast.
We are going to take questions at the end of the session. So anyone who has questions for Rogelio, please put them in the chat. I'll collect those and moderate a Q&A at the end. And for now, we're going to go directly on to the next presentation, which is Tracking and Projecting Trends in Hispanic Latino Pandemic Deaths, the Challenge of Missing Racial Ethnic Data. And this is going to be presented by Beth Jarris, who is at PRB.
And can you see my screen?
Yes, we can.
Okay, perfect.
Yep.
Actually, we can see a
slideshow.
No, we see a through the looking glass version of. Yeah, try it again. You may want to share just the window of PowerPoint rather than your entire screen.
Okay, we'll try that.
There we go.
Okay. And can you see it in slideshow mode now?
No, we are still looking at the regular mode.
Let's try this one more time. How about now?
Yep, you got it.
Yay, third time's the charm. Excellent. Thanks, everybody. So I want to start out by thanking my co-authors, Mark Mather and Lillian Kilduff at PRB, and explain a little bit about the background of this project. So Unidos US asked us to assist with tracking both cases, COVID cases and deaths in the Hispanic and Latino population in 6 states around the country: Arizona, California, Colorado, Florida, Nevada, and Texas. And I'm going to focus mostly on California and Texas when I talk about data quality. And so They asked us to track trends in sort of the historical pattern of cases and deaths, and also to do some what if scenario projections of, sort of if the pandemic was brought under control, sort of low level case and death projections, and then if there were massive peaks like we saw in the winter, high level projections. So as you can imagine, to accomplish this, we wanted a couple of things. Reliable time series data on cases and deaths by race and ethnicity, and we'll talk about that for most of the presentation, the data quality issues. Good benchmark data to serve as the launch point for the projections related to that time series. And then ideally, age-specific case and death, race ethnic data, so we could calculate case fatality rates to place an upper bound on our projections. As you can imagine, when we're doing projections, sort of one of the reasonableness tests is, have we projected more deaths than we would expect, sort of if the pandemic had swept through the entire population with case fatality rates that we've seen to date. So to set that upper bound, we really wanted case fatality rates. Didn't seem like too much to ask for, but we found that among those 6 states, the quality of the data was very different. California has really great timely data on deaths by age and race and ethnicity, and case data by age and race ethnicity as well. And I don't think that I'm speaking with too much of a California bias when I say that of all of the states we were working with, California's data was the best. Florida had case and death data by age or race ethnicity. And my favorite part about Florida was that the data is in PDF format. So if you want the detail, you have to scrape PDFs, which was not my favorite part of this project. And so I also want to give a shout out to the COVID tracking project, which Rogelio had mentioned previously. We ended up really valuing all of the work that team did to do that scraping and data collection, because that made much of the rest of this work much easier. And then Texas, as you just saw, has some decent death data by age and race and ethnicity, but the case data is a different story. And so let me tell you that story. If we look at California's case fatality rates, so you can see here the different racial and ethnic categories that were reported in California. Cases are the next column, deaths in the third column, and then a case fatality rate based on reported cases and deaths by race and ethnicity. And these case fatality rates sort of pass the face validity test. They seem reasonable given what we know about COVID. And they seem reasonable in part because there's been good tracking. If we look across all of the data collected, if you look at that very bottom row, the proportion of cases that had racial and ethnic data included, about 3/4 of cases in California have racial and ethnic detail. And almost all death records in California have racial and ethnic detail. So there's a little bit of an underreporting problem of racial and ethnic detail in cases, but not huge, at least not when we compare it with Texas. When we look at Texas, the story gets much more complicated. As you can see on the right-hand side of the screen, those case fatality rates are absolutely bonkers. If those case fatality rates were real, half of people who get COVID would not survive it. And we know that while it's a deadly disease, that's not quite the truth. And then in addition, when Texas counts up the number of cases with data, more than 10% of those cases for which they report racial and ethnic data are labeled unknown. So if we take that into account, that unknown racial and ethnic data, Texas still has only 4% of cases that have racial and ethnic detail reported. So calculating those case fatality rates is nearly impossible. Also, we wanted to look at trends in Hispanic and Latino cases over time. And this is telling us that there are only 26,000 of those as of January 2021. We know that that's not true, that there's more than that small share of Texas's 1.5 million total COVID cases that are among the Hispanic and Latino population. So the question we were struggling with is, how do we fix this, and that's reasonable and defensible? So clearly this data is not going to work. So we sort of listed out the options. We could use the reported totals. I've already sort of stolen my thunder in the punchline. The pro of that is there's no pro to using that approach. Data is terrible for cases in Texas. The con is massive underestimates. And so really the 3 approaches that we looked at were applying the proportion among the cases that had reported race and ethnicity and applying that to the total known cases in Texas. Straightforward approach, consistent with reported totals. The potential bias there is that it doesn't account for any bias in the reporting. So are cases more likely to have racial and ethnic data in the Hispanic community than in others? Are they less likely? So another option would be to, because the death data reporting is so much more robust, there's far more racial and ethnic detail, could we apply those proportions to the known cases to sort of back into what the distribution of cases was? Really straightforward, again, consistent with reported totals, but doesn't account for differences in mortality, which we just heard about. So that's potentially a big flaw in that approach. And then the third approach is to reverse engineer cases based on death data. So again, take the thing that we have the most detail about, and then case fatality rates from other states where we have better data, and try to use that to reverse engineer the number of cases that Texas would have had in the Hispanic and Latino population. Maintains consistency between case and death data, but other states' mortality experiences probably have not been the same. So you may end up over or understating cases in Texas. And so what did we end up with? What you see here, the blue bars represent the projections. So if we took data from September and used each of these different fill in the gaps scenarios, what would the December projection have looked like? So the first blue bar, if we took that 26,000 cases as our benchmark and did a 3-month projection, we would have projected about just over 300,000 cases. Using proportion of known cases, it's closer to 590,000, so on and so forth. So the third bar is using the percent of known deaths, and then overall crude case fatality rate for California and Florida. And it would be great if we could compare these to actual cases, but Texas's case data reporting hasn't gotten better in the last couple of months, so we don't have the December numbers to compare to. We do, however, have how well these models performed when we looked at death data. So the way that we were looking at the scenarios, we're projecting.
2-minute reminder.
Perfect. I'm just about to wrap up, so it's great timing. So we took the total projected cases and then used some mortality rate projections based on that. And what we found is that if we use the as reported model, we far underestimated the number of deaths. The green bar that you see on the far right there is what the total number of deaths that had happened through December 2020, about 13,500. The proportion of known cases of all of the scenarios we tried was the closest. And that's good because that's actually the model that we ended up using. We had made this decision, and then post processing went back and checked against the December data and found that actually had fit the best. Although I think a case could have been made for any of those. But really the takeaway here, the bigger picture, and this is something that many others have noted, is I feel like we really need better demographic data on COVID-19 cases. Pothak et al. Found that only California, Illinois, and Ohio had sufficient age and racial and ethnic detail to investigate disparities in case fatality rates, controlling for age. Controlling for age within the framework. And so really, if there was anything I could ask for, it would be better demographic detail, both on cases and on deaths.
Thank you very much. We are going to take questions at the end in a Q&A discussion. So if you have any questions for Beth, please go ahead and put them in your chat, and I will collect those and moderate a session at the end. And for now, we're going to move right along to our next presentation, which is an early warning system for impending local outbreaks, learning to live with COVID-19. And we will hear from Peter Morrison from Morrison and Associates.
I'm now embarking into the abyss to make sure I can share my screen. Hold on.
Peter, I think the easiest thing might be if you go up to the menu at the top that's slideshow.
Yep.
And then play from start. That'll get you to the same place.
Right. Very good. Can you guys see it?
We can.
Outstanding. Okay. Today I want to highlight what has evolved as an opportunistic study that I undertook last spring, which evolved and expanded thereafter into a collaborative effort with my colleague Dave Swanson at UC Riverside. It is still a work in progress, but the ideas that I'm going to throw out here today could be transferable to other communities. And I think, it exemplifies a purely applied demography approach to a problem, that evolved last spring that none of us could have anticipated, and we just kind of fell into it. All right. Let's start out with background and context. As you can see here, I've made 3 points. Local officials need current actionable forecasts of COVID-19 spread for precise geographies. What they need is, for a particular locale, they need to know what might happen in a week or two. But we don't yet know, just how far out on the horizon. Secondly, these are forecasts, short-term forecasts that could aid and are really designed to aid in what I call an adaptive response approach to easing restrictions for public facilities, schools, restaurants, and so forth. You all recall what it was like back in the spring when everybody was saying, well, you gotta cut back and then you gotta open up, and nobody knew what was going on, and kind of how do you deal with that in any systematic way. And this study leveraged 2 natural experiments in island communities, one Nantucket County, which is the island of Nantucket, where I reside, and is the global international headquarters of Peter Morrison and Associates, and San Juan County, Washington, which Dave Swanson has interest in, and that's kind of, the bone for that dog. An overview, this is kind of what we did. We adapted a simple demographic model that Dave came up with, which is useful for estimating the near-term risk of COVID-19 spread across each of these island community populations. The model incorporates the ARIMA method, and there's a reference at the end of this thing, which is the literature on this that Dave came up with. He's the modeler guy, and it's a forecasting tool that's well suited to the early quiescent stage that preceded the COVID-19 outbreak, at least on Nantucket, and I suspect in many small communities where you have one case, and then a few days later there might be another one, and then next week there were 2 cases, and people start scratching their head and say, is it time to worry yet? So this is the quiescent stage, and what we did is we tracked outbreaks occurring in at 2 test sites in early 2020 into the summer and onward in these 2 counties. And the aim was to prompt a timely adaptive response upon the first sign of an outbreak. This is the sort of thing where by the time you have a burgeoning number of people showing up with symptoms at the hospital, you've already missed a week of spread. And so the idea is, when do you know that you're on the verge of a big outbreak? At each test site, our model signaled an early warning alert, lengthening the window of opportunity for immediate response. And the window here is maybe having a week to jump on what you've decided to do, in the same way that if you're doing hurricane planning or tornado planning, you've got hours or possibly a day or 2. You already have an agreed upon protocol that when it looks like it's going to strike, you start boarding up the windows and you take steps to prepare for the crisis that lies ahead in a matter of hours. And we suggest that this might be a model that could support local emergency planning. The advantage of the model is that it has a minimal appetite for data. It just requires the cumulative number of confirmed COVID cases reported over time. The applicability of the model is correspondingly narrow. It's applicable only at the quiescent pre-surge stage. Once the contagious spread has manifested itself, the assumptions on which it's based are violated, and so the model is really no longer applicable. For Nantucket, we used the cumulative case count from March 22nd to May 1st to calibrate it. implemented the model for Nantucket, produced daily cumulative projections, baseline extrapolations from May 2nd to July 5th, and actually more recently, we've done them subsequently, I just don't have the data. And then Dave's model attaches a lower and upper 95% prediction intervals. And these baseline extrapolations essentially reflect containment measures, whatever they were, if there were any, that were in effect during the observation period. And at this time, the only thing that was going on Nantucket was quarantining and contact tracing, and it was pretty immediate. This is sort of what the data look like, cumulative cases. If you look at the red lines, people were getting concerned when the cases jumped to 10, a total of 10 for the whole island. And then they kind of steadied off there for a couple of weeks. Then they started to head up to another level, then they leveled off again. So this was kind of quiescent. People would come, go into the hospital and say, I've got symptoms. They'd immediately quarantine them and nothing would happen. And the projection to the right shows what this model implies if that regime continued. Let me just talk briefly about the potential applicability. The projection model is designed to signal immediate need to suppress community spread. That could be quarantining, contact tracing, prohibitions at larger gatherings, whatever. I liken it to a credible early warning alert for a hurricane warning or a tornado alert triggers what have to be pre-authorized actions which buy valuable time. You got to have decisions made that if the number gets to this, you immediately do this. You don't put it through a decision-making process. Once the surge becomes exponential, you've really lost the window of opportunity for early intervention. This is, as I say, a work in progress. For me, it's kind of catnip applied demography, something that is fun to do, and I tried to make it applicable at an early stage in Nantucket. And this was kind of how
Peter, this is your 2 minutes remaining warning. Thank you.
Okay, I'm just about done. When you think about what a model like this could do, remember it's got very limited applicability. It just kind of signals a yellow light and then a red light and says, you better do something right now. You can think of the kinds of actions that could have been taken. In the case of Nantucket, a lot of the spread that was happening turned out to be construction crews that were going out, doing what people do on Nantucket, which is they tear down houses and build bigger ones. There was a real problem of renters who were coming into the island to stay for a week, visitors, and what happens if they get infected during the stay? What do you do? And also there was a proposal to cap attendance at popular beaches or hours, late in the evening at bars. Here are the details on the stuff we worked with, the ARIMA model, Swanson and Taman, book called Subnational Population Estimates. And the companion study that Dave has done is the San Juan County Companion Study, Early Warning COVID-19 Alert for San Juan County, which is appearing in a magazine called Northwest Citizen. There's a link there. So that's the story. Thank you.
Thank you, Peter. Okay, so we are going to hold questions until the end of our session. We'll have a few minutes there to discuss. So if you have questions for Peter or any of our other presenters, please put them in the chat and I will collect those for the end. And meanwhile, we're going to move along to Mike Hollingshouse, who is going to be talking about decomposing the effects of age structure on per capita COVID-19 death rates. Mike is from the Chem-C Gardner Policy Institute at the University of Utah.
Hello, welcome from Utah. I hope you're all doing well today. Can you see my screen?
We can.
Okay, great. I come from the state of Utah. I'm happy to talk with you. And to present this research. Before we begin, I want to thank a lot of collaborators who provided great input and review on this. Pam Perlich, a current mentor, Emily Harris, Mallory Bateman, Natalie Young, or colleagues, and Eric Albers, current graduate assistant, who helped with some of the initial data. So this is actually, this research already published in July 2020 last year. If you're interested, you can go to our website, gardner.utah.edu, and actually just look at the full report that was published. So the issue here really was, so here's a little background. Utah, is very different in terms of population size from, say, Texas or California. You're dealing with 10%, even of the population of those places. We got about 3.2 million people, but of course, COVID-19 was very troubling for everyone. Some things we knew and that were true and are still true is actually, compared to the nation as a whole, Utah has a pretty low per capita COVID-19 death rate. And back in the summer last year, when people were talking about this, what do we do? A lot of people were saying, well, we're doing very well. Actually, we have a low death rate. And I guess that's one way to look at it. But of course, it's very concerning. It was very early in the pandemic. We didn't know what was happening. And as a demographer, we think about things like age structure, right? So, of course, Utah had a low COVID-19 death rate, but it also has the youngest median age of the states in the nation, about 31, 32 years compared to, the US, which is about 6 or 7, maybe 8 years higher, depending on your estimates you go to. So, and we know COVID is deadlier for older adults. So, of course, a natural question, demographers who've had, you're talking about maybe the second or third week in a demographic methods course, you talk about age structure. So the question is, how much of this lower death rate is attributable to age structure? This is actually important. It interprets how people judge their response to the pandemic. And of course, we see underlined here, little time and data. So this is a limited resources. And, this is very small here, conceptually a small issue compared to the larger question. But in terms of the reality an applied demographer deals with, it's actually a big problem and a big part of what you deal with. So to answer this, I use decomposition. So this is a solid, clean way to answer this question. I don't see it used a lot in applied work, but it's been very interesting to me. The Kitagawa method in Preston et al.'s Demographic Processes textbook is very straightforward, easy to use. And it actually provides just a simple answer to this question. How much of Utah's lower death rate compared to the US is attributable to age structure? Of course, we had some challenges with this. It requires the age-specific rates and population compositions for both populations being compared. And the published crude rates that you want to compare, you may have noticed, usually don't come with the underlying age-specific events or population data, right? I look at crude rate published and I'm like, hey, cool rate, I want to look at how you calculated that. And, it's like, you can't find it. So that's usually a challenge, particularly at a time when people were struggling to get data together, responding to their own requests, data uncertainty. And another issue is, of course, the crude death rates, the cost-specific per capita death rates from COVID-19 were changing a lot, being published. And then I also knew in the back of my mind, hey, someone's probably going to ask me to update this at some point. It would be nice to be able to do this in a fairly easy fashion. So our solution was to combine data sources, and it comes from this observation of this fact that the age-specific rates are actually defined by the age distributions of deaths and the age distributions of population. If you combine that with crude rates, you can actually reconstruct the age-specific death rates. And then, of course, you have the age distribution of the population. That's the population composition. You can perform the decomposition. So to reformulate, this is the boring slide or the interesting slide, depending upon who you are. I find this the interesting slide. Some people find it the boring slide, but it's important. The idea here is we take the ratio of the age-specific distribution of deaths and the age distribution of population. Take that ratio. And it's pretty easy to show, actually, that the age-specific death rate for an age group I, or any category really, that specific death rate is equal to the ratio of those distributions times that crude death rate. Practically speaking, this means you can assume what distribution of deaths and the distribution of population composition, perhaps take it from another source. if you think it's constant over time, you can estimate those age-specific death rates for any published crude death rate. And so that's what I ended up doing. So quick on data, what we did here, what was done here. The per capita COVID-19 death rates published from CDC's COVID data tracker. This is what a lot of people are going to look at, right, and try to make decisions based on. July 14th of last year, also August 12th, which I believe was the day I submitted the abstract for this presentation, updated for that. And then February 4th, 2021, which you may recognize as the day that is today, I updated this morning to see what the new results are. So you will see brand new results. Okay. The age distribution of COVID-19 deaths I took from CDC provisional counts, July 14th, 2020, and the age distribution of population from the U.S. Census Bureau for the U.S. and our own KMC Gardner Policy Institute estimates for Utah for July 1st, 2019. 2020s weren't published yet. We make our own population estimates. They're actually pretty similar to the Census Bureau's in many respects, but we have different assumptions regarding missionary migration, which is actually pretty impactful for Utah, and retirement migration and the student population. So here are the reconstructed age-specific death rates for the US and Utah. These are the logs using this method. And you can see these look like pretty straight lines, which, when you're looking at the log, that means it's increasing at a pretty constant rate with age, what we call the Gompertz model. And Utah's rate was lower than the US rate. So I could look at this and say, hey, standardizing by age, look, death rate's lower. To me, that tells information. For a lot of people, they want information in a different format.
Mike, this is your 2 minutes left warning.
Well, we're at a good moment, so thank you. So July 14th, 2020, October 12th, and 4th of February, you can see the different COVID-19 death rates that were published. I won't go into detail about what exactly all the denominators and everything in those are. In fact, a lot of times you don't know exactly. But you can see what the differences were. In fact, today the difference 82 per 100,000. Attributed to age structure, I would say today 32.6 per 100,000 was attributed to age structure of that difference. And that's actually 40%. That surprised me. That's up a good deal from the 23% we had in July last year when this was published. So it's pretty easy to track over time. So the overall assessment of strengths, this decomposition directly answers the question. It's very easy to implement and update. The assumptions are very transparent. In fact, they can be tested. And one thing I plan to do shortly is to go get some additional data. I've explored some and compare how well did these distributions stay constant over time. The population distribution, age distribution, seems that's fairly safe. The death distribution, that assumption should be tested. You can adapt it to any demographic rate, so pretty useful. Course limitations, usual data limitations, scarce data, suppressed data, differences in reporting, and so forth. The result, of course, is subject to the assumptions, right? But at least we've explicitly stated them. That's always true, right? And then potential confounders. Answering this is the effect of age doesn't address potential issues of for example, racial ethnic composition, which will be correlated with age and with COVID-19 death outcomes. And the data on that were so scarce for Utah and still are. But, this could very well account for Utah having a smaller share of minority population compared to US as a whole, could very well account for some of these other differences and confound age effects. Thank you.
Great, thank you very much, Mike. Again, we are going to take questions at the end. And so if you have questions for Mike or other speakers, please put them in the chat. We're going to move on to a talk from Chris Hess of Cornell University. And this talk is entitled Scraping Big Data with Helena to Understand the COVID-19 Pandemic's Effect on Rental Housing Markets. And we can see your slides, Chris, so take it away.
Thank you for that introduction. I am happy to be presenting this work that I did with I'm doing really with some colleagues at the University of Washington, which is my alma mater. And I would be remiss if I don't acknowledge the support that the Center for Studies in Demography and Ecology has continually provided for this project. And so as the title pretty explicitly states, we're trying to understand COVID-19's effect on rental housing markets. And so the goals of the present study are twofold. Where at the neighborhood level, we're trying to understand the degree to which COVID-19's associated impact on markets, which expectations are in the direction of slowdown, has varied across different types of neighborhoods. And this is to inform whether the neighborhoods where households most at risk of housing cost burden and housing instability in general are seeing any COVID-related declines in typical rents. And then at the market level, we're trying to estimate the difference in typical rents and as well as just the current state of affairs associated with the pandemic. And this would be to inform what direction local markets are going for housing policy and program administration during this period while ACS data are unavailable. So we really see a complementary role of the scrape data for that. And I'll talk more about the data themselves in a second. But the background is that prior to the COVID-19 crisis, that 40% of renters were already cost burdened, which is to say that they were paying a disproportionate share of their income towards housing. We usually use a 30% threshold for that. And this is symptomatic of decades of rising housing costs, particularly in expensive metros like Seattle or New York. But that it's also emblematic of stagnating wages, particularly among those at the bottom 50% of the income distribution. One part of the cost burden dynamics is a longstanding racial and ethnic inequality in who's exposed to cost burden, something that's really only widened since the Great Recession. And so, you know, we have read or in journalistic accounts, there's talk about the downturn related to COVID, meaning a growing number of households unable to pay monthly housing costs. And we're just trying to shed some light on the degree to which there could be any relief in terms of housing costs, associated with the pandemic. And so these expectations about what's happened have been covered, at length within the New York Times, Washington Post, in terms of there being reports about weakened demand for urban neighborhoods, a booming real estate market among suburbs, given the lower price per square foot usually, and that more broadly that there's some high-cost metros like San Francisco, where there's been this exodus of households due to work from home. And in the case of New York City, I haven't seen much looking at neighborhood differences, but in the case of New York City, there's evidence that the neighborhoods with greater Black and Latinx representation have seen a much, much smaller decline in rent compared to those with greater shares of non-Latino whites. And so this brings to what we're trying to add to this discussion, which is using rental housing ads as a data source to be able to understand things right now before a probably preferred data source like the ACS can really shed light on something at particularly at a smaller geography like census tracts. And so we're using these because they're spatially and temporally granular data on what rents are being asked at, in some place at some time period. And so the listing sample itself is useful for descriptive analysis about what users on a given platform would find. To the right, I have an image of the Craigslist index, which is the data that we'll be talking about. And analyzing a given platform's listings is akin to the analysis of Zillow or StreetEasy or other particular platforms that's been pretty prevalent across media. And the challenge that we're really trying to face with this study is how to be able to make a solid or a reliable inference about the overall market after attending to the differences in the composition of listings on a given platform as it relates to the population of interest in terms of housing units. And so we've been collecting data for about 2 years now. Nationally, we've been collecting data for about 2 years with this ongoing process, giving us rental ad data for the largest 100 metropolitan areas in terms of Craigslist specifically. This is a programming by demonstration tool where we have been able to automate the process of collecting this information and Craigslist is but one of many, but it is from surveys about how landlords advertise housing and how tenants search for housing. It's among the largest, and there's no real barrier to usage, which is an important part of it, capturing more of the affordable side of the market than other platforms. And so we have about 35 million ads collected nationwide since the beginning of 2019. And I'm going to start now just by describing some of the associations that we're seeing between different neighborhood characteristics and year-over-year trends through 2020. And so the first is that it's pretty clear that the higher rent neighborhoods are where we are seeing a predicted downward trend. And that's in contrast to a more affordable or lower rent neighborhood where there's been essentially no change or even a small increase as its predicted trend. This unsurprisingly holds when looking at median income at the neighborhood level. So neighborhoods where neighborhoods where the ACS would say the median income is about $200,000. That's where we're seeing these 2% declines. And elsewhere in lower or middle income neighborhoods, there's been a remarkable consistency in rents not changing. So it really goes to show that the popular narrative around slack real estate market and declining rents in particular is focused on particular types of areas within that broader market. And then finally, if we look at neighborhood prevalence of cost burden, the average being about 40% of renters in a given neighborhood being cost burden, we can see that in those places where households are already hurting and paying a disproportionate share of their income towards rent, that's where there's been either no change, no relief, if not some increase in rent. And so the declines being limited to higher cost, higher income areas, in contrast to persistent rent levels in lower rent, lower income areas. And this together points to the importance of continued economic assistance, particularly to lower income households, to help shore up the ability to pay rent and provide stable housing. And then to talk briefly about how we're trying to adjust for sample selectivity, we're using multi-level regression and post-stratification weighting to adjust the composition of the Craigslist sample for the sort of non-response of sorts that we think about through how users select into using these particular platforms. So we're using the most recent 5-year estimates to get weights on the distribution of renter-occupied housing units by neighborhood and bedroom size. And the effect of this is to upweight the listings that represent segments that are underrepresented on Craigslist, as well as to downweight listings that are from oversampled parts of the market. What we're finding, and this is certainly the most—
Chris, I'm sorry to interrupt. This is your 2-minute warning.
Wonderful, thank you. So to briefly talk about this, the multi-level regression and post-stratification weighted median rent estimates tend to be lower than our unadjusted Craigslist estimate, certainly closer to the prior 1 year or the most recent 1 year ACS estimate for a given county. The difference due to the weighting and adjustment is most notable in coastal metropolitan areas, which goes to show potentially the sort of overrepresentation of larger, more expensive multifamily units in those particular areas. But comparing these adjusted estimates for 2019 and 2020 has so far corroborated that rent declines are limited, not just to particular neighborhoods within metro areas, but at a broader level, it's focused more on particular markets that are more expensive and hotter, so to speak, to begin with. So I really appreciate the attention, and I look forward to the Q&A.
Great, thank you very much for that presentation. We have one presentation remaining, and we're going to hear from Natalie Williams from the University of Washington. If you have questions for Chris or anyone else, please put them in the chat box. We will get to the Q&A at the end. And meanwhile, we'll hear from Natalie Williams, an innovative non-pharmaceutical intervention to mitigate SARS-CoV-2 spread, probability sampling to identify and isolate asymptomatic cases. Natalie, we saw your slides for a moment.
Okay, can you see and hear?
We can, yep. You're
Okay.
not in slideshow view yet.
Oh, I put on my slides and I forgot to unmute myself. So how about now? We good to go?
Yep, that's perfect.
Okay, I'm Natalie from the University of Washington. I'd like to thank my team for this, working with me on this project. They're listed here, and this is based on a paper that's now available in medRxiv. So the problem that's going on now, this is a very different take than my previous colleagues who were looking at how do we understand what's going on now, and this is more of an application of how to mitigate spread. So that's what we're proposing here. The problem that's going on now is that the testing of COVID and isolation occurs at symptoms. People feel sick, they go in and get tested at that point, and then we isolate them. Hopefully, effectively isolate them. The problem is that people are infectious before symptoms. Anywhere from people can be infectious for 0 to 7 days before they develop symptoms. And during that period, they are spreading the disease. And estimates have shown in different places that between 60 and 80% of infections come from a case that was pre or asymptomatic. So we are actually, when we isolate people after they test at symptomatic state, we're isolating them much too late. So that's why testing and quarantine are not effective at mitigating spread. They are effective at developing treatments for people, but they're not effective at all at mitigating spread. So we come up with a solution for this. We just thought this might work, and in this article we test if it works or not. So the idea is to go out and find the virus. So right now it's invisible before people have symptoms. So what we need to do is identify the asymptomatic cases. We test them and then quarantine pre-symptoms and use that as a method for mitigating the spread of the virus. The problem is asymptomatic cases, the reason we're not testing and isolating them is because they're invisible, right? So how do we find, the key here is how to find those asymptomatic cases. And because they're invisible, there's no actual way to go looking for them. So what we suggest is just go to the entire population and do probability sampling in the whole population. So that's where our acronym sampling, testing, and quarantine comes from, STQ. So how does this work? We tested in our model 3 different sampling strategies: just simple random sampling, we cluster sampling on communities, and cluster sampling on schools. In our model where we tested this, we assumed 100% accuracy of the tests and immediate results. That's not entirely accurate, but the model can be adjusted to look at the efficacy of the STQ method if we assume less than 100% accuracy. We also looked at different quarantine procedures. So someone gets tested and they test positive. We only quarantine that individual. We call them our test positive individual, whether they have symptoms or not. Another thing we tested is quarantining the test positive individual and all their household members without testing those household members. And we also looked at quarantining the test positive individual, everyone who lives in their household with them, and in addition, those symptomatic cases, those people who go to the doctor and test positive with symptoms. So our question here is the relevance of this STQ method can be demonstrated if we can show, is it effective? And we can also look at how many tests are required for certain levels of efficacy and what frequency is required for efficacy. Because obviously you could take the STQ procedure and you could test every person in the population every day, and then yes, of course it would be effective, right? But the question is, we don't have the money or the organization to do that right now. So how many tests are required to make it do something to mitigate spread is the real question. So we tested this with an agent-based model. This is a simulation model, so we create a fake population that looks like the population of Seattle. And in our case, there are about 600,000 people, and they live in neighborhoods, as there are neighborhoods in Seattle, and they have an age distribution similar to Seattle as well. Agent-based models are known to be very effective for testing different intervention scenarios. We don't have any problems with missing or biased data because we create a fake population, so we know everything about that population. The negative is that it's a simulated simulation. It's not based on real data, so this is like what we think could happen, but it is not a projection. So we made this fake population in Seattle with 600,000 people, and we seeded it with 5 initial infections of COVID. And we tested the model in various ways for an R0 of 2.0, 2.6, and 3.0. We started our STQ intervention on day 30, 60, and 90. We assumed the quarantine was fully effective, and we assumed that there were no internally imposed infections. So nobody came in, nobody traveled in this model. So big question, is it effective? So our first test, we used simple random sampling, and we had 50,000 tests for the population of 600,000 people. We applied those tests every 7 days, starting at day 30. And then we looked at varying ways of isolating people. So the black lines here are no STQ intervention. So the black solid line is, actually I see that my dots and dashes did not show up on here, I'm sorry. The highest black line is nothing was done, completely unmitigated intervention. The next lowest black line is where we only isolated the symptomatic people, which is basically what we're doing now. And then the lowest black line is where we isolate the symptomatic people and their household members. The pink lines are for our STQ procedures. And you can see that with 50,000 tests at 7-day frequencies, you can mitigate the spread. You don't mitigate it very much by isolating just the testing positive people, but you mitigate it much more, when you isolate the tested positive people and their household members. And even further, the lowest line is where you isolate the tested positive people, their household members, and those who are symptomatic. Our next test, we looked at, our next example, we looked at different varying numbers of tests. The black line here is a completely unmitigated spread. And to that, we compare what happens when you do 10,000, 50,000, 100,000, or 200,000 tests every 7 days. And of course, you can mitigate the spread better the more tests you use. Notably, at 200,000 tests, that's a third of the population, you basically end the epidemic. Then we said, well, okay, what if we don't have 200,000 tests every 7 days? What happens if we have the same amount of tests, but we apply them either a whole bunch at once with lower frequency, or we apply fewer tests with greater frequency? So when we looked at things like 10,000 tests every day, or 50,000 tests every 7 days, or 100,000 tests every 14 days, the results come out very similar. What you see here is that with different frequencies and testing numbers, you can delay the peak of the spread a little bit, but they basically end up the same. And then the third thing we did, this is where it gets interesting, when we use various sampling procedures, like the same number of tests, the same frequency, 50,000 tests, which isn't that much every 7 days, your sampling strategy does matter. And you can see here, when we use simple random sampling, the blue line, that's about similar to what we find for cluster sampling on communities, but very interesting when we sample on schools with the same number of tests at the same frequency, that mitigates the spread much more effectively. And the key here is that the reason for this is that we're looking for asymptomatic cases. And if you recall, children are more likely to have asymptomatic cases versus symptomatic cases. So if we go looking for this invisible virus in the places where it is invisible, then we're more likely to find those people. And when we find those children, we isolate their households as well, and it becomes much more effective.
Natalie, I'll interrupt you here with a 2-minute warning.
Great, I think I'm on my last slide here. So yes, we found out that with the simulation model, we found out that this STQ procedure can actually effectively mitigate the spread of the SARS coronavirus. We can decrease symptomatic prevalence. This is what I showed you in my slides here. What I also didn't show you is that it decreases the cumulative symptomatic cases over time, and it delays the peak of the symptomatic prevalence. The most effective ways to implement this are more tests, well, of course, but one of the keys here is with 50,000 tests every 7 days, you can actually do a lot. Of course, with higher frequency, it's more effective, obviously, but if you only have a limited number of tests, more tests at lower frequency is more effective than fewer tests at greater frequency. And then the key that we found here is that cluster sampling on schools, which is really cluster sampling on children, actually makes this method much more effective at mitigating spread. And these are extra slides, but that's all I have for you. and I will return us to the group.
Great, thank you so much. So we have a few minutes remaining for questions from our viewers, and I will start off by taking a minute to thank everyone for watching and thank all of our panelists. This has been a really interesting discussion. I have one question that came in already, and this is for Natalie. Beth asks, she says her first question was going to be how you would address test accuracy, and since you talked about that, she would like to know, did you or will you try out any other accuracy rates? And I actually have a related question, which is, what if, you know, in reality, we cannot get instantaneous results? The best we can seem to do here at UW-Madison is about 2.5 days. And I wonder if you tested out a delay in the results.
Yeah, so we can absolutely test those. I mean, we control the population, so we can test any of those things we want. Actually, I haven't done it because I don't think it would be meaningful. So if the test accuracy, for example, to get a best question, if we would assume that 50% of tests are accurate, running that model would end up with the same results as running half the number of tests. So if we say we're going to run 50,000 tests at 100% accuracy, that would come out, the model would show us the same result as running the model would show us the same for if we ran 50,000 tests at 100% accuracy, we'd get the same result if we ran 100,000 tests at 50% accuracy. So I haven't run it because we can just estimate it there. And I think the same thing would happen, Malia, with your the amount of time between when the test is taken and you get the result. You would just see, you would move your like peak prevalence over 2.5 days.
I don't think so, actually, because
No.
in the meantime, you'd be allowing all of those asymptomatic people to spread further.
But it would be the same thing as if we did an immediate test 2 days later, would be the same thing as doing a.
Oh, I see what you're saying.
Days before.
I see what you're saying. Yeah.
So I don't think it would make any difference in the curves that I showed you.
Yeah, interesting. So let's see. I'd love to. We have a couple of other questions for Natalie, actually, but let's see if we can have some questions for a few of the other panelists. I actually had one for Rogelio. I was wondering, you talked a little bit about the possibility that occupation by ethnicity might be influencing the age distribution of COVID cases and also deaths. And I wondered if you've thought about using any occupation by ethnicity data, and I'm especially wondering about by gender and the sort of complicated intersection of women of color in nursing, and also what's happened with the labor market as women have been leaving the labor market.
Yeah, I haven't found any data that are on the mortalities that have the occupational status represented. Whenever that comes out, that's going to be extremely valuable information. But I think that that being on the front lines, people that are more likely to have to work and cannot work outside of the home and cannot have that luxury, I think that there's evidence, I think at least suggesting that that may be going on. I think the other thing with the Latino community is that we also find that you have people that are living in more crowded conditions as well as the multi-generational homes where you have a grandparent, you have parents, and then children. So that, I think, amplifies the spread if somebody catches it at the workplace and then brings it home. Yeah.
And Beth, this is a sort of a follow-up question, since there's some overlap in the work that the two of you were doing here. I wondered also about your thoughts on how vaccine hesitancy, especially amongst the Latino population, might affect the disparities in CFR by ethnicity going forward. just kind of a thought experiment. I realize we have no, we haven't vaccinated enough people for that to become a problem yet, but.
I definitely think it's, well, and I think that's one of the reasons why looking at the case and death data by race and ethnicity and age and gender becomes so important, because we can't answer questions like that without the data to support it. So if we have states that aren't reporting cases by race and ethnicity, then it's going to make it really hard to, if one of our biggest states isn't reporting good case data, then the national totals are going to be off as well. So.
Is this just related to what's on the death certificate and the demand for really rapid processing of death certificate data?
Yeah, so I should be clear. So the death certificate data is much better and much more complete, even in states where we were seeing some, like Texas, I think, was 96% of deaths of the preliminary death data had racial and ethnic detail, which is where some of the mortality related work can keep going ahead. It's the case data where the racial and ethnic details really missing.
Interesting.
And that's a big piece of that is because collecting health data is a state level function. CDC provides guidance and suggestions, but ultimately the data collection happens at the states, and all of the states have different systems.
Great. So we have a question from Rochelle Winkler. Hi, Rochelle. Nice to see you. For Chris, who would like to know, since you were already collecting housing data this way pre-COVID, I expect you had a different original purpose. Can you say more about the original motivation and about other applications or questions you hope to be able to answer?
The original motivation was to provide the city of Seattle with it was part of a broader effort to assess data on the rental market, but to provide the city with the means to understanding trends in small area rents to a degree that they otherwise weren't able to, or had to wait, for a considerable amount of time to be able to do with ACS data. And there's other issues therein with the fact that in a market like Seattle, it's just moving so quickly, and ACS data at the neighborhood level are always going to build in like 5 years ago responses. But we've used these data for a variety of papers related to rent estimation, and that's more for to help with something called small area fair market rent policy, and a couple other things. We've also tried to assess the degree to which different neighborhoods are over and underrepresented on Craigslist, as well as other platforms. And then the sort of another arm of this research has been to look at discourse online. And so that's looking at differences in how housing and neighborhoods tend to be talked about based off of the composition of the population in the surrounding area, as well as an emergence of sort of a discussion about home fortification in neighborhoods that are gentrifying. So that's a short spiel.
Thanks. And I also wondered, can you detect anything related to the evictions crisis in your data? Or have you thought about trying to? Sorry.
We've been wanting to link the data at the neighborhood level that Matt Desmond's eviction lab is producing, but the closest we could get would be to see our neighborhoods where there's more eviction filings, using those data, seeing different trends in rent or similar. There's no good way to link, like was a housing advertisement that popped up, somewhere where someone got evicted.
Interesting. Oh, Beth, I already answered this question from Natalie. So I have one more question that I was going to ask for Peter. One thing that we know from infectious disease epidemiology is that and actually this might apply to Natalie's models too, is that the interface between populations is really important. And since you were looking at 2 island communities, and in the case of Natalie's model, you introduced some number of cases at the outset and then didn't allow there to be movement from other locations or the introduction of more cases. What are your thoughts about how these models might need to be different in a setting that was not literally an island?
Let me try answering that. The island concept is intriguing because there's isolation. And then when you consider that all of the people who arrive or depart do so either at an airport or at a ferry terminal, you come up with all sorts of ideas. And we've thought about this a lot, and I guess the most provocative idea that one has, it kind of builds off of Natalie's notion of so many people are going to be asymptomatic when you get this interchange of people, perhaps in whatever context socially, that being able to find out where you might do the testing. In the case of Nantucket, it turns out at construction sites where people gather in trucks, show up at a work site, and then work together for the day, have lunch together, and then go home and have spread exponentially depending on how many people were at the work site. So this notion of clustering, I think, is a very powerful one and needs to be adapted to the particular circumstances of the community. Another thing, in the case of Nantucket, it would be ideally adapted to very small pieces of geography, census blocks where people are very densely housed, sometimes workers.
Yeah, not unlike the college dormitory settings. That there's some interesting questions for Natalie in the comments here that I think we're not going to officially get to because we are out of time. This is our last session, so if anybody wants to hang around for another 5 minutes and ask these questions, you may find an audience for them. But I will formally close the session and thank everyone for joining us. It's been really interesting. Thanks all.
Thank you.
Thank you, Malia. Natalie, I would say the college dormitory model is the ideal one to think of generalizing to circumstances that you find. I made the point on the chat thing about different immigrant communities where you'll find extremely densely settled housing units, highly crowded, and the indicator there might simply be a census measure like, is this a household?
Well, and related to, I'm sorry to interrupt you, Peter.
Type thing that immediately took up.
Related to that, Rochelle had asked
Sure.
about the similarities between the approach that you're modeling, Natalie, and the what universities are actually doing, and wondering if you could compare them as a benchmark to a real world example.
Okay, so for the sampling on more densely populated areas, absolutely. So I like the idea of sampling on the larger households. And the model we're using, I think 55% of transmissions are between household members. So that's why when you find one household member who has it, and you don't even test the other ones, but you can make the assumption that most of them are going to have it, it's actually a good assumption. And then you can catch a lot more cases without using up tests. That's why it works so well with that quarantining household members. And of course, it would work much better and more efficiently if we cluster our sampling on larger households. So I thank you for that comment. And then if you think of a college dormitory as a very large household, then definitely test in college dormitories. But the interesting thing about that is I've already got some comments on this paper and another sampling procedure we did, and people are worried about disproportionately hurting certain people or concentrating on certain types of people with our procedure. Because what we're saying to do is, if I catch that you're positive, I'm not even going to test your household members. You're all shut up for 2 weeks. That's it, right? And so if you sample on particular types of households, such as larger households, if you concentrate on them, then you are disproportionately shutting down certain kinds of people. So I think we have to be very careful with those things. I think it's definitely worth testing, because all we're saying is we're just testing how you can make this more efficient. But the nice thing about college dormitories is nobody's going to feel particularly bad if we test out of college dormitories, and I won't feel particularly bad because those are not particularly disproportionately repressed peoples. So that's the answer to your question. So thank you for the idea, and I will definitely test on that. And there's no way it will be anything but way more effective.
Natalie, it occurs to me that UW-Madison's testing strategy for students who live on campus is very much like what you are proposing. So if you needed a real world example, you could maybe benchmark to it.
So you're talking about Wisconsin, because I'm at UW too, I'm assuming. So I'll look that up. My UW has things like that too, like offer testing to everybody. And a lot of universities and places do that. But the difference is it's still a voluntary.
Oh, no, it's mandatory. All students have to be tested twice a week.
Oh, okay. So that's different. That's interesting. I'll take a note. Thank you. Because
Rochelle also says in the comments here that Michigan Tech's testing strategy is almost exactly what you're doing as well. So,
okay. So I will definitely look at those because everything I've seen so far is like it's available to everybody whenever you want, but that's still a voluntary sampling case.
Yeah, this was not true in the fall, but this spring semester they have changed the protocol now. All students and a probability sample of staff who are on campus as well have to be tested.
That's awesome.
It's not a perfect test, but as you said, I think it's that might not matter in terms of the way the model works.
Yeah. So. If it's not voluntary, then that's huge. So thanks.
Yeah, so there may be a couple of examples out there.
Great, thank you.
Well, this has been really thought-provoking. So thank you all for coming, and I wish you the best of luck riding out the rest of this pandemic with your very interesting pandemic projects. Bye-bye. Have a good one.
Bye. Good seeing you.